pharmaceutical distribution center in Tampa, Florida, occupied a nondescript warehouse facility in an industrial park near the airport. Med Supply distributors held all required federal and state licenses to distribute controlled substances to pharmacies, clinics, and hospitals across the southeastern United States. The company had operated for 9 years with a reputation for reliable service and competitive pricing in the pharmaceutical wholesale market. The facility maintained proper security protocols required for handling controlled substances. Surveillance cameras monitored all areas. Access controls restricted entry to authorized personnel. Inventory management systems tracked every pill from receipt through distribution. Regular audits by state pharmacy boards had found only minor administrative issues that were quickly corrected. From every external perspective, Med Supply was a legitimate business operating within the heavily regulated pharmaceutical distribution industry. But embedded within its operations was a systematic scheme to divert millions of doses of prescription opioids into illegal markets through falsified records and corrupted oversight systems. The investigation began when a data analyst at the DEA's Diversion Control Division noticed statistical anomalies in controlled substance distribution patterns. Federal law required pharmaceutical distributors to report suspicious orders that exceeded expected medical use. The reporting threshold varied by drug and region, but patterns exceeding normal medical practice were supposed to trigger alerts. Med Supply's reports showed nothing unusual. Their controlled substance distributions fell within expected ranges for a company serving their market area. But when the analyst compared Med Supply's distribution patterns to demographic and medical data for the regions they served, discrepancies emerged. They were distributing oxycodone at rates 40% higher than population health statistics would justify. The excess wasn't dramatic enough to trigger automatic alerts, but it was consistent over multiple years. Legitimate medical practice fluctuated based on seasonal factors, public health trends, and changing prescribing patterns. Med Supply's distribution showed steady growth that didn't correlate with any documented changes in regional healthcare needs. The analyst examined which specific pharmacies were receiving the elevated oxycodone shipments. Most of Med Supply's customers were conventional chain pharmacies, independent pharmacies serving normal patient populations, and hospital pharmacies with unremarkable ordering patterns. But 17 pharmacies across Florida, Georgia, and Alabama were receiving quantities that significantly exceeded what their patient populations should require. These pharmacies were located in small communities with limited populations. A pharmacy in a town of 5,000 residents was ordering enough oxycodone to provide 30 pills per resident monthly. Medical data showed that legitimate opioid prescribing for chronic pain affected perhaps 5 to 8% of populations. The pharmacy's orders suggested prescribing rates 6 to 8 times higher than medical necessity could explain. DEA investigators visited several of the high-volume pharmacies under the guise of routine compliance inspections. What they found were operations that appeared superficially legitimate, but showed signs of functioning primarily as drug distribution points rather than conventional pharmacies. The facilities had minimal inventory of common medications for routine health conditions, but they maintained extensive stocks of high-dose opioid medications. Prescription records at these pharmacies showed unusual patterns. Individual patients were receiving prescriptions for multiple opioid medications simultaneously, combinations that legitimate medical practice would rarely justify. Patients were obtaining refills at frequencies exceeding recommended dosing schedules. The prescribing physicians for many prescriptions were located hundreds of miles from the pharmacies filling them. The investigation expanded to examine the physicians writing the prescriptions. Several operated pain management clinics that functioned as pill mills, facilities that prescribed opioids with minimal medical examination or justification. Patients would visit these clinics, pay cash fees, receive cursory examinations, and leave with prescriptions for large quantities of opioids. The pill mill model had been documented in previous DEA investigations, but this network showed more sophistication. The clinics maintained medical records that appeared to document legitimate pain management treatment. Physicians performing the examinations held valid medical licenses. The prescriptions were technically legal because licensed physicians had written them for patients who physically presented at the clinics. But the medical justifications were fabricated. Patients with no documented injuries or chronic conditions were diagnosed with severe pain requiring high-dose opioid treatment. Medical histories were created or exaggerated to justify prescriptions. The clinics were operating as prescription factories, generating documentation to support systematic opioid diversion rather than providing genuine medical care. The connection to med supply became clear when investigators traced the supply chain. The pharmacies receiving diverted opioids obtained their inventory exclusively from med supply. The distributor provided the pills that pharmacies dispensed based on the fabricated prescriptions. Without med supply's willingness to supply the pharmacies, despite their suspicious ordering patterns, the diversion scheme couldn't function at its existing scale. Federal law required distributors to maintain effective systems for detecting and reporting suspicious orders. Med Supply had such systems on paper, but they had been deliberately designed or manipulated to avoid triggering alerts on the diverted shipments. The company's compliance department was either incompetent or complicit in facilitating the diversion. Financial investigation revealed that Med Supply's owners and certain employees had financial relationships with some of the pill mill operators and high-volume pharmacies. Money flowed between entities through consulting agreements, equipment leases, and loans that appeared designed to share profits from the diverted opioids while maintaining superficial separation between the distribution company and the diversion destinations. The scheme's sophistication extended to record manipulation. Med Supply's inventory management system showed controlled substances being shipped to the suspicious pharmacies, but the quantities were documented as falling within acceptable ranges based on pharmacy size and patient population. The deception occurred in how pharmacy profiles were configured in the system. A pharmacy in a small town would be classified in the database as serving a much larger population than actually existed. This inflated baseline made excessive orders appear normal relative to the supposed patient population. The manipulation was subtle enough to pass cursory audits, but systematic enough to enable massive diversion without triggering compliance alerts. The diverted opioids were reaching illegal markets through multiple channels. Some patients receiving prescriptions from pill mills were legitimate users who had become addicted and were obtaining medications through the corrupt system. But many were obtaining prescriptions specifically to resell the pills on the street. They would fill prescriptions at the corrupt pharmacies, then sell the pills for cash to dealers or directly to users. Street prices for diverted pharmaceutical opioids were substantially higher than legitimate prescription costs. A pill that cost $10 through insurance or cash payment at a legitimate pharmacy might sell for $30 to $50 on the street. The markup created profit opportunities at every level of the diversion chain. The pill mill clinics charged cash fees of $200 to $400 per visit. For this fee, patients received prescriptions worth hundreds or thousands of dollars in street value. The clinics operated with minimal overhead, generating enormous profits by processing high volumes of patients through brief appointments focused on prescription generation rather than actual medical care. The pharmacies received standard reimbursement from insurance companies or cash payments from patients for the dispensed medications. But the volume they processed created substantial revenue beyond what a legitimate pharmacy serving their actual geographic area could generate. Some pharmacies were processing 500 to 800 prescriptions daily, volumes that would require multiple pharmacists working full shifts at maximum capacity. Med Supply profited from the high volumes they supplied to the diversion network. Pharmaceutical distribution operates on small margins per pill, but profits increase with volume. By supplying the corrupt pharmacies, in addition to legitimate customers, Med Supply expanded their business substantially beyond what the legitimate market in their region would support. The human cost of the diversion was measured in addiction and death. The opioids flowing through the corrupt system contributed to the addiction crisis affecting communities across the southeastern United States. People who might have avoided opioids if access required legitimate medical justification became addicted after obtaining pills through the permissive pill mills. Some progressed from prescription opioids to heroin or fentanyl when pharmaceutical supplies became too expensive or difficult to obtain. Overdose deaths in areas served by the diversion network exceeded state and national averages. The connection wasn't immediately obvious, because the deaths appeared to involve prescription medications obtained through seemingly legal channels. Only detailed investigation revealed that the prescriptions themselves were fraudulent despite appearing legitimate. The investigation required coordination across multiple DEA divisions. The Diversion Control Division handled the pharmaceutical distribution violations. The Enforcement Division investigated the criminal conspiracy aspects. Financial investigators traced money flows. Intelligence analysts mapped the network structure and participants. Federal prosecutors developed a strategy to prosecute the scheme at all levels simultaneously. Charges would be brought against Med Supply's executives for failing to maintain effective suspicious order monitoring and for conspiracy to distribute controlled substances. The corrupt pharmacies would face charges for dispensing prescriptions known to lack medical legitimacy. The pill mill physicians would be prosecuted for distribution and for filing false statements in medical records. Building cases required extensive evidence collection. Investigators obtained records from Med Supply showing distribution patterns over multiple years. They documented that company executives had been warned by their own compliance staff about suspicious ordering from specific pharmacies, but had failed to take required action. Email communications showed discussions about the high-volume pharmacies and decisions to continue supplying them despite obvious red flags. Pharmacy records were subpoenaed and analyzed. Investigators documented prescription patterns that couldn't be explained by legitimate medical practice. They identified individual patients who had filled prescriptions at multiple pharmacies for overlapping opioid medications, a pattern indicating doctor shopping and diversion rather than pain management. Medical records from the pill mill clinics were examined by expert physicians who provided opinions that the documented examinations and diagnoses didn't support the opioid prescriptions that were written. The medical justifications were fabricated or grossly exaggerated compared to documented patient conditions. Undercover operations placed agents as patients at pill mill clinics. They documented that physicians performed minimal examinations, asked perfunctory questions about pain, and wrote prescriptions for high-dose opioids without establishing legitimate medical need. The investigations confirmed that the clinics were operating as prescription factories rather than medical practices. The coordinated enforcement actions occurred on a Thursday morning in October. Federal agents executed search warrants at Med Supply's distribution facility, 17 pharmacies, and 9 pill mill clinics across 4 states. The simultaneous operations were designed to prevent evidence destruction and ensure that the entire network was disrupted at once. At Med Supply, investigators seized computer systems containing distribution records, compliance files, and communications between executives and high-volume pharmacy customers. Financial records documented the relationships between the distributor and the diversion destinations. The evidence revealed that Med Supply had knowingly supplied pharmacies they understood were engaged in diversion. The pharmacy searches uncovered massive quantities of opioid medications in inventory that exceeded legitimate business needs. One pharmacy in a town of 6,000 had inventory sufficient to provide every resident with 60 opioid pills. The pharmacies also had prescription records showing the systematic patterns of excessive prescribing and doctor shopping that characterized the diversion operation. The pill mill clinic raids documented the superficial nature of medical examinations and the fabricated medical justifications for opioid prescriptions. Patient files showed near-identical examination notes across hundreds of patients, suggesting documentation was created formulaically rather than based on actual medical assessment. The seizures included approximately 2 million doses of various opioid medications, with a street value exceeding $30 million. The inventory represented diverted pharmaceuticals that would have reached illegal markets if the operation had continued. 73 individuals were arrested in the coordinated enforcement actions. 12 were Med Supply employees, including executives, compliance officers, and distribution managers. 27 were pharmacy owners, managers, and pharmacists from the corrupt pharmacies. 19 were physicians and medical staff from the pill mill clinics. 15 were individuals involved in recruiting patients and facilitating the diversion. The prosecution revealed the organizational structure and profit flows. Med Supply executives had received annual bonuses tied to sales volume that created incentives to supply high-volume customers regardless of legitimacy concerns. Compliance officers who raised concerns about suspicious orders had been pressured to approve shipments to maintain business relationships. The corrupt pharmacies had generated millions in revenue beyond what their legitimate patient populations could support. Pharmacy owners had used the profits to purchase additional pharmacy locations, expanding the diversion network. Some had invested in real estate and businesses unrelated to healthcare, laundering diversion proceeds into apparently legitimate assets. The pill mill physicians had earned enormous incomes from the cash-based examination fees. Some were processing 50 to 70 patients daily, generating daily revenue exceeding $10,000. Over multiple years, several physicians had earned millions from the scheme while providing essentially no legitimate medical care. The patients who participated in the diversion faced varied consequences. Those who were genuine pain patients who had become addicted through the corrupt system were often treated as victims and offered treatment options. But individuals who had been obtaining prescriptions specifically for resale faced prosecution for distribution and fraud. The sentencing phase demonstrated serious consequences for pharmaceutical diversion. MedSupply's CEO received 20 years for conspiracy and failure to maintain required compliance systems. Other company executives received 12 to 18 years. Compliance officers who had been complicit received 8 to 12 years. Pharmacy owners and pharmacists who had knowingly participated in the diversion received 15 to 25 years. The sentences reflected their professional responsibilities and the violation of positions of trust in the healthcare system. Physicians operating pill mills received 20 to 30 years, with enhanced penalties for their abuse of medical licenses. The financial penalties were substantial. MedSupply was ordered to forfeit profits derived from the diverted pharmaceuticals, totaling approximately $40 million. The company also faced civil penalties from state pharmacy boards and potential private lawsuits from individuals harmed by the diverted medications. The cumulative financial impact forced the company into bankruptcy. The corrupt pharmacies had their licenses permanently revoked and were shut down. The facilities were sold or converted to other uses. Communities that had relied on these pharmacies for legitimate prescriptions needed to find alternative providers. The closures created temporary hardship for legitimate patients who lost convenient access to pharmacy services. The pill mill clinics were permanently closed and their medical staff lost licenses to practice medicine. Several physicians faced additional charges from state medical boards beyond the federal criminal cases. The loss of medical licenses ended careers and eliminated future earning capacity for individuals who had spent years in medical training. The investigation's impact on opioid availability in affected regions was mixed. Legitimate patients with chronic pain conditions faced increased difficulty obtaining prescriptions as physicians became more cautious about prescribing in the wake of the pill mill crackdown. Some patients who had legitimate medical need suffered when access to pain management became more restricted. But the overall opioid supply available through diversion channels decreased significantly. Street prices for pharmaceutical opioids increased as supplies became scarcer. Some users shifted to heroin or illicitly manufactured fentanyl as alternatives became more accessible than diverted pharmaceuticals. The shift created new dangers as users encountered drugs of unknown potency and composition. The pharmaceutical industry implemented enhanced compliance measures following the investigation. Distributors across the country reviewed their suspicious order monitoring systems and increased diligence in reporting concerning patterns. The case became a training example, demonstrating consequences for distributors who failed to maintain effective controls. State pharmacy boards enhanced oversight of high-volume pharmacies and implemented data-sharing systems to identify prescribing patterns suggesting diversion. Cross-referencing prescription data across pharmacies made doctor shopping more detectable. Some states implemented prescription monitoring programs, requiring physicians to check databases before prescribing controlled substances. Medical boards increased scrutiny of pain management practices and prosecuted physicians who operated outside professional standards. Continuing education requirements were enhanced to ensure physicians understood appropriate opioid prescribing practices. The medical community faced pressure to address the role physician prescribing had played in creating the opioid epidemic. The communities affected by the diversion network experienced complex effects. Some residents who had been addicted to diverted pharmaceuticals entered treatment programs and began recovery. Others continued struggling with addiction, shifting to different drug sources when the pill mills closed. Local law enforcement reported changes in crime patterns as the drug market dynamics shifted. 3 years after the investigation, pharmaceutical opioid prescribing in the affected regions had decreased by approximately 40%. Some of the reduction represented elimination of inappropriate prescribing through pill mills, but some represented overcorrection, where legitimate pain patients had difficulty obtaining needed medications because physicians feared regulatory scrutiny. The balance between preventing diversion and ensuring access to legitimate pain management remained difficult to achieve. Enforcement actions addressed widespread diversion but created challenges for patients with genuine medical needs. Intelligence assessments concluded that pharmaceutical diversion remained a significant problem despite the successful prosecution. Other distributors and pharmacies continued operating similar schemes in different regions. The economic incentives persisted despite enhanced enforcement. The investigation demonstrated that sophisticated diversion operations could function within apparently legitimate business structures for extended periods before detection. The scheme had operated for at least 5 years before statistical analysis identified the anomalies that triggered investigation. During that time, millions of doses of diverted opioids had reached illegal markets. The case emphasized the importance of data analysis in detecting diversion. Manual audits and inspections had failed to identify the scheme because individual transactions appeared normal. Only aggregate pattern analysis revealed the systematic nature of the operation. Enhanced use of data analytics became a priority for diversion control efforts. 5 years after the enforcement actions, the southeastern pharmaceutical distribution landscape had stabilized under new management and enhanced oversight. Legitimate businesses had filled the market gap left by MedSupply's bankruptcy. Opioid distribution patterns more closely aligned with medical necessity as distributors implemented more rigorous suspicious order monitoring. But the human toll of the diversion scheme continued affecting communities long after the operation was shut down. Individuals who became addicted to diverted pharmaceuticals struggled with recovery. Families who lost loved ones to overdoses carried permanent grief. The economic costs of addiction treatment and lost productivity persisted for years beyond the enforcement actions. The MedSupply case became a landmark prosecution in pharmaceutical diversion enforcement. It demonstrated that distributors could be held accountable for failures in suspicious order monitoring. It showed that entire diversion networks, including distributors, pharmacies, and prescribers, could be prosecuted through coordinated investigation. The precedent influenced how future diversion cases were investigated and prosecuted.